First of all, I'd like to thank the organizers and Xstral to provide me the opportunity to briefly review on radiobiological principles in the treatment of benign fibromatosis. Due to restricted time, I would like to concentrate on Dupuytren's Contracture, which covers a prime example of a fibroproliferative disease with contractile properties. As given in the webcast series, low-dose radiation therapy is reasonably effective in reducing or abolish the clinical symptoms of Morbus Dupuytren and other hyperproliferative diseases. The radiobiological basis and molecular or cellular mechanisms contributing to the modulation of this benign hyperproliferative fibromatosis disorders, however, are far from being fully explored. This talk thus aims to summarize current concepts on the anti-proliferative and immune modulating properties of low-dose radiation exposure. Aberrant cell proliferation is involved in the hyperproliferative tissue formation, which is induced by either a genius unknown reason, by secondary injury, or by a variety of trigger mechanisms. In general, the course of Dupuytren's disease comprises 3 consecutive phases which are associated with a different radiation responsiveness. First, a radiosensitive hyperproliferative initial phase characterized by increased numbers of fibroblasts, myofibroblasts, and early nodal and cord formations is evident. Second, an volumental phase with a decreased radiation sensitivity in line with the established of fiber bundles resulting in contractures is evident. And finally, a non-radiation sensitive residual phase with collagen fibers dominating the connective tissue is present. Consequently, the rationale for the use of ionizing radiation to affect these hyperproliferative disorders may be related to the presence of radiation-sensitive target cells like mitotic fibroblasts, myofibroblasts, and molecular mechanisms at the early stage of disease. With regard to radiation-responsive target cells, the proliferative phase seems to be the most relevant, as it is mainly driven by radiation-sensitive fibroblasts and myofibroblasts prior to the formation of nodular constructures. In response to fibrogenic cytokines, most pronounced transforming growth factor beta-1 released by inflammatory cells, fibroblasts differentiate into myofibroblasts. This process results in proliferation, excessive production, and matrix deposition of extracellular components, most prominent collagen, fibronectin, elastin, and proteoglycans, and the development of nodules and cords. The cellular sources of this myofibroblast are still not entirely clear. They may, however, include resistant or circulating CD43 positive stem cell-like fibroblasts, progenitor cells, or may derive from parasites, endothelial cells, or epithelial cells, with the latter to include a mechanism of epithelial mesenchymal transition. There is still few literature on the impact of ionizing radiation on the fibroblast, myofibroblast, and fibrocyte system. In the late 80s, based on morphological and proliferative characteristics, by Rödel and Rödel defined a differentiation sequence of a fibroblast-fibrocyte cell system with terminally differentiated senescent or post-mitotic fibrocysts to display the final step of differentiation. These post-mitotic cells are characterized by a downregulation of C-FOS and a specific capacity for the synthesis of collagen types 1, 3, and 5 in proteoglycans. Taken into account these sequences, single-dose irradiation of fibroblasts in the dose range of 1 to 8 gray induces terminal differentiation into post-mitotic fibrocytes at a high percentage level, while irradiation of long-term cultures with fractionated doses revealed a less marked reduction of fibroblast proliferative activity. Further, these effects are more pronounced at the early onset of radiation. Moreover, the lifespan of senescent fibrocytes is limited and shortened by approximately 40% if induced by ionizing radiation as compared to a physiological development. Following environmental stress, including ionizing radiations, levels of reacting oxygen species, including hydrogen peroxide or hydroxyl radicals, increase dramatically, resulting in a significant damage of cellular macromolecules, induction of DNA damage, and disturbances of a multitude of signal transduction pathways. The latter directly affect the production of inflammatory and fibrogenic cytokines, including activation of latent transforming growth factor beta. In sum, these cytokines act as chemoattractants, mitogens, and differentiation inducers for the fibroblast, myofibroblast, fibrocyte system. Notably, as depicted in the graph, addition of 3 oxygen radicals to cultured fibroblasts from Dupuytren's palmar fascia dose-dependently either increases or inhibit proliferation at lower and higher concentration. Thus, elevated level of ROS induced by ionizing radiation may exceed a threshold of ROS production to inhibit fibroblasts and myofibroblast proliferation. Indeed, elevated levels of growth factor cytokines produced by platelets, macrophages, and other cell types, including myofibroblasts, have been reported in Dupuytren specimens. By this, elevated levels of pro-inflammatory cytokines were observed in fibroblast cultures isolated from Dupuytren's nodules as compared to normal palmar fascia. These factors include, among others, fibroblast growth factor, platelet-derived growth factor, epidermal growth factor, connective tissue factor, isotypes of transforming growth factor beta, and tumor necrosis factor alpha. Among these mediators, TGF-beta is well recognized to constitute a key player as the cytokine is critical in many facets of the fibrogenic process, such as ROS generation and the synthesis of extracellular matrix components. Although the onset and progression of Dupuytren's contracture have extensively been investigated, the mechanistic basis for the proliferation elements is still not completely resolved. However, the process includes at least 2 differentiation components, a fibrogenic, angiogenic, proliferative, and an inflammatory and immune cell component. Indeed, histological studies identify the presence of a multitude of immune cells in early Dupuytren's contracture. In particular, the number of macrophages correlated with the quantity of myofibroblasts. As given in the picture, macrophages characterized by surface CD68 expression are localized in alpha smooth muscle actin positive myofibroblast nodules, and their localization correlates with an increased detection of cytokines like TGF-beta 1 and pro-inflammatory interleukin-6 in nodal tissue. On a mechanistic level, resting macrophages are activated, for instance, by injury or stretch, and in turn secrete elevated levels of a variety of cytokines, including interleukins, chemokines, and TGF-beta. These mediators will, on the one hand, activate additional macrophages. On the other hand, these cytokines will impact on fibroblast, myofibroblast differentiation and proliferation that is further augmented by myofibroblasts, interleukin-1, TNF-alpha, and growth factor expression. Thus, a direct interrelationship between ionizing radiation and macrophage activation may constitute an additional mode of action. Indeed, with regard to cytokine production, a hampered pro-inflammatory TNF-alpha or interleukin-1 secretion from human or murine macrophages stimulated by lipopolysaccharide has been reported. In addition, inflammatory macrophages irradiate treated with low doses exhibit a reduced oxidative burst capacity and diminished activity of inducible nitric oxide synthase expression, resulting in reduced levels of ROS mounting in oxidative burst or nitric oxide production. Taking into consideration the prominent role of macrophages in both inflammatory and fibrogenic processes, a diminished production of cytokines ROS and NO may further contribute to reduced myofibroblast proliferation activation and to the beneficial effects of radiation therapy. It has further been shown that a therapeutic benefit of steroids in early Dupuytren's contracture may be due to a diminished leukocyte recruitment. In line with that, endothelial cells are crucially involved in the regulation of inflammatory processes, both by a local recruitment of immune cells from the peripheral blood and their capacity to secrete a multitude of cytokines and growth factors. Applying adhesion assays, we and others have reported on the reduction of leukocyte adhesion to 50% of the control levels at 4 hours and 24 hours after a low dose X-ray exposure. In addition, we observed an increased ROS production from stimulated endothelial cells with a local maximum following a 0.5 gray exposure. Based on these findings, it is reasonable to assume that a reduced recruitment of immune component cells like monocytes or macrophages may further contribute to the proliferative and functional effects of radiation in the treatment of Morbus Dupuytren. In summary, hyperproliferative disorders are based on complex pathophysiological networks and considered to comprise a system biological disease. Accordingly, one may assume that the empirical proven benefit effect of low-dose radiation therapy is mediated by a modulation of a multitude of cellular components and pathways involved. Although considerable progress has been achieved during the last decade in the understanding of radiobiological mechanisms being prominent at a low-dose radiation exposure, still a multitude of open questions exist. Thus, intensive translational and clinical research efforts, as well as the development of further basic preclinical models, are seriously needed to unravel additional contributing factors and mechanisms. And by this statement, I'd like to thank you for your attention and will be happy to take your questions.
Thank you, Dr. Rödel. The first question coming in from the team, why do you think that there is not more radiation therapy being used for hyperproliferative disorders?
This question is hardly to be answered because I think in Germany and in other countries, low-dose radiotherapy for hyperproliferative diseases is an established treatment in a variety of diseases. However, in England or in other countries, the use of low-dose radiotherapy is somehow regarded with danger by the people that think that they might have cancer risk by treatment, and therefore they do not dare to perform treatment with this low-dose radiotherapy in a lot of countries. However, to my point of view, this treatment is not so dangerous as thought, and the incidences and the fear of inducing cancer is neglectable by the doses that we use in this low-dose radiotherapy.
Okay, thank you. Next question is just an observation that it seems that the lower dose per fraction, lower than 3 gray, worked in the cell experiments. Do you think that 3 gray is too much?
Concerning Morbus Dupuytren, it's quite difficult to answer this question because we need two components in the treatment. We need immune modulating activity, which is mainly covered by a dose of 0.5 gray, and we use another higher doses for the to impact on the proliferation of fibroblasts and myofibroblasts. So I think we need this higher doses to scope with the proliferative activity of fibroblasts and myofibroblasts, and we also need lower doses in the surrounding of this diseases for the modulation of the immune system. This is also implicated in the progression of the disease.
Okay, thank you. Last question regarding sort of the age of the patients that you're using radiotherapy. Is there an age that you I guess would not recommend treatment for someone younger than a certain age?
So Emma referred to the guidelines of the German DECRO and society, and they recommended not to treat patients younger than 40 years.
Okay, and we do have one final question. There hasn't been much literature demonstrating secondary malignancy for Dupuytren's or keloids. Do you think that there's a particular study that you would cite for your patients in terms of secondary malignancies?
So to the best of my knowledge, there's indeed no literature and no particular study on this special topic. So we really had to refer to more general publication from Professor Prof, for example, dealing with the cancer risk of low-dose radiotherapy, which was published a couple of years ago.
Okay, thank you very much.